Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Michael Stoker, Ketan Patel, Samuel Rouleau, Shannon Marcus, Millie Casse, and Clay Smith. Okay, let's skip straight to the second article, titled Pre-Hospital Trauma Compendium, Evaluation and Management of Suspected Pelvic Fractures, an NAEMSP, a position statement and a resource document out of the Journal of Pre-Hospital Emergency Care. That's right, we're talking about pelvic fractures, which means we're talking about pelvic binders, not something we cover a lot of articles on. Although we did talk about unstable pelvic fractures a while ago in October, we didn't talk that much about binders. But here, we're going to be focused on using pelvic binders in the pre-hospital setting. It seems like, because there is some evidence for benefit in the hospital setting, that this has been extrapolated to pre-hospital, and, well, it hasn't been very well proven in the pre-hospital setting. This position statement challenges routine pre-hospital use of pelvic binders. And this would definitely have implications for the emergency department and pre-hospital care because it means they wouldn't be putting it on anymore. But of course, we would still want to put it on if we needed to. They did kind of a rapid review of the literature and looked at 151 articles, mostly poor quality data. And the authors found that there's just not a very good field diagnostic accuracy for applying a pelvic binder to what is a suspected pelvic fracture. There's only unstable injuries in about 9 to 14% of cases that get a binder, so we're really not being very specific. And there's no consistent reduction in the amount of transfusions that these patients required or their mortality. And misapplication was very common, about 50%, so it's not even being put on properly in a lot of these cases. There are some documented but not well quantified iatrogenic harms too. So we see that we're overusing it, we're not using it very well, and then in some circumstances, we're actually causing harm. And the authors really try to get to the point that don't forget about all the other stuff in trauma. Just because a patient has a binder on doesn't mean it's not something else that's causing their shock. Just because they have a pelvic fracture doesn't mean something else isn't causing their shock. Less than 10 to 30% of pelvic fractures actually cause instability in those patients. So in an unstable patient, it might not even be their pelvic fracture that's really making them unstable. I'm not saying it's helping, but all the same. And physical exam for this, well, it doesn't work very well. We're not very good at examining for this. You really need the x-rays to know what's happening. So the authors propose reconsidering the use of pre-hospital pelvic binders. We have no obvious sign that it benefits patients in the field setting, and you might just be better off waiting until they get to the emergency department. So this sort of makes sense, but it doesn't. What it really comes down to, I think, is that I think pelvic binders, they can be useful. If they're useful in the emergency department, then they can be useful pre-hospital. It only sort of makes sense. But, EMS, they have so limited time and they have a strange environment. It's hard to use some of these treatments effectively. And so probably for this reason that it's not going to be very useful. If we had a better measure of which patients actually need a pelvic binder, then I'm sure it would be more helpful pre-hospital. But for right now, we don't necessarily have that. I can only think of select few cases where I've seen patients come in with a binder, but I guess in some scenarios, in some regions, it might be a lot more common. So just like we're seeing that C-spine immobilization might not be very useful, maybe pelvic binders in the field aren't that great either, and people should just focus on getting that patient to the hospital. In a spoonful, pelvic binder use in the pre-hospital setting might need close scrutiny. Certainly, though, strong recommendations are going to be hard to make with this low quality of evidence that we have. And then the fifth and final article titled Percutaneous Pigtail Catheter versus Chest Tube for the Treatment of Pediatric Traumatic Hemothorax, an Eastern Association for the Surgery of Trauma multi-center study out of the Journal of Trauma and Acute Care Surgery. I think at this point we're pretty accepting, at least in adults, that pigtails are as good as chest tubes for whatever you've got built up in your chest cavity. If you've got a pneumothorax, then hey, Pigtail is going to do the job. If you've got a hydrothorax, then hey, Pigtail is probably going to do the job. If you've got a hemothorax, guess what? Pigtail's probably going to do the job. Assuming you're stable. It's a little bit different if you're crashing, then hey, just get a tube in there as quickly as possible. That's the priority. But in a stable patient, it's a Pigtail's going to do the job. We have a lot less evidence for pediatrics though. And that's what these authors wanted to try to contribute, and so they did a retrospective study of almost 550 hemodynamically stable pediatric patients with some kind of a hemothorax or hemopneumothorax. And these patients were recruited across numerous trauma centers. Now, this was very interesting, and we see that they're pretty much equal in most regards. The failure rate from chest tube to pigtail catheter was not statistically different and numerically lower for the pigtail catheters. The complication rate was also quite similar between the two. In a univariate analysis, the complication rate of pigtails was slightly higher, but that was really just driven by ventilator-associated pneumonia, which physiologically, doesn't really make any sense that would be related to the size of your chest tube. So I think that's just, bad luck that one was higher. The drainage volumes were lower for the pigtail catheter. So what everybody's a little bit afraid of, and it's going to get clogged. It's not going to get all the fluid out. Well, that seems to be true in some regards. You get less fluid out if you put in a pigtail, but that's not a patient-centered outcome. It's not something that we care that much about. However, this is all retrospective data, and this is not the kind of thing that you can study well retrospectively because, well, when chest tubes were the norm, if you decided to put a pigtail, it's probably because you had a reason to put a pigtail, or you're a particularly woke person who likes to put pigtails instead of chest tubes. Or you had, some other reason that maybe the patient was, very small, or they were just so stable that you didn't feel like it made sense to put a big chest tube in them. These are not going to be comparing apples to apples. But even not comparing apples to apples, we've seen that they're pretty much equivalent. So it seems kind of interesting that that'd be the case. But we still can't draw any real conclusions about the success rates of pigtails unless we're randomizing the patients, or we have some reason to think that these two populations would be the same, which we don't necessarily from this study. So in a spoonful, this is really weak support for the use of pigtail catheters for hemothoraces in pediatric patients, but it's a little bit of support nonetheless, and we don't really expect that there'd be a big difference in this regard between pediatrics and adults, so it's probably fair to put a pigtail in for stable patients with hemothoraces. Okay, and that's all the articles from this week. Let's do a quick wrap up of everything we talked about. And then we looked at the evidence behind prehospital pelvic binder application, and it's really quite limited. And then from the fifth and final article, more data on the use of pigtail catheters compared to chest tubes for hemothoraces, even in children. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about that you missed? We did a review of how to reverse antithrombotics. We talked about a trial that looked at steroids in community-acquired pneumonia in Kenya. And then lastly, we covered the 4 largest articles on non-operative management of appendicitis. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.